Assalamu alaikum. Good afternoon. Today is January 15th, 2023. डॉक्टर आगा ने बताया कि 2023 जो है वो 2022 से बेहतर जा रहा है, तो एक स्टेटमेंट है, गौर कीजिए. Last time we presented, Dr. Vas Masood, he presented about resistant hypertension, and this is a follow-up session. I volunteered to present one of my cases, which is here. And then after that, we'll request Dr. Ali to give us a follow-up on his case. So this is my patient. This is back in 2016. So at that time, he was 63. Now, of course, you can do the math. He retired. So he works as quality assurance manager. And the guy is very high tech. He maintains spreadsheet in the Excel for all his blood pressure readings. He was diagnosed to have high blood pressure when he was in his 40s, and then had a good control with 3 to 4 drugs. It was really in the last 10 years that he had blood pressure inching up above the means, and all different parameters for stage 2, stage 3 hypertension. When he presented, he had some microalbuminuria. This was 263 or something, or less than 300. He was seen by another nephrologist and hypertension specialist before he came to my clinic, who completed the workup for secondary hypertension. So at that time, his renin and aldo level were all within normal limits. So I actually not only looked at the notes from the nephrologist, but I also requested the lab report, which were sent in, I think, into one of the outside Quest labs, and those levels were within normal limits. He did not know if there was renal duplex or metanephrines, which I actually ended up completing. And all the records which I received, I did not see any hypokalemia or metabolic alkalosis. Other comorbid conditions included type 2 diabetes for the last 10 years. We already discussed about microalbuminuria. He had coronary artery disease. He underwent stenting back in 2006. BMI is 39. He has hyperlipidemia. He's good. He also has mild edema on the exam. He underwent colonoscopy and meniscus repair in the past. Socially, no tobacco. Alcohol was maybe very social, but no regular alcohol intake. NSAID use was once or twice a month. His family history: father died at age 69 from congestive heart failure. Mother alive at 85. And there was strong history of high blood pressure on the mother's side. Mom had high blood pressure, same pattern, diagnosed in 40s, and continued to take multiple medications like this patient was taking. And mom's side has high blood pressure. His blood pressure on my visit was 163/90, BMI, as I mentioned, 39. On physical exam, I noted trace edema, but otherwise, exam was unremarkable. So I just cut paste his med list, and I highlighted the number of blood pressure medications he was already on. So he was taking a beta blocker, carvedilol, 25 milligram twice a day. HCTZ gradually increased to 50 milligram a day. Losartan was 100 milligram a day. Spironolactone, 50 a day. He was also taking doxazosin, 2 milligram twice a day, and Imdor, 30 milligram a day. He was seen by both cardiologists as well as nephrologists in the past for these. So they had all this medical regimen. He was also on aspirin, statins, and other routine drugs. So labs: creatinine was 1.1, potassium was 4.3, bicarb 24. Excuse me, BUN 15 is microalbumin to creatinine ratio at that time was 268, hemoglobin 14.8. Renin, aldo, and cortisol were within normal limits. So we took the history, and I ended up sending the test of, I checked his thyroid, TSH, which was okay.
And a very quick question. I'm sorry to interrupt. Do we have the numbers on the renin and aldo somewhere?
So I will present those. I do not include in this, for the originals were, since they were kind of outside, so I've noted them in my original consultation. I couldn't find the exact numbers, but they were, so they were within normal limits. Let me put it that way. I actually tried to dig those numbers, but I could not. So metanephrines and the free, this is the screening blood test, they were okay. The metanephrines was 0.33 and normetanephrine was 0.92. Their cutoff was less than 0.9, and he didn't have any presentation suggestive of that facial flushing or anything that I would think of that as one of the etiology. I got the kidney duplex. There was no renal artery stenosis. And then his kidney size was pretty decent, close to 12 centimeter on each side. So we diagnosed him as essential hypertension at that time, despite of all these things, because we did not find a clue. So his potassium and bicarb remained normal throughout. This is like really the screenshot of the labs I had from 2000. I think I had some labs from 2016. Potassium was normal. So in my system, whatever 2022 to more recently, potassium and bicarb, they were never abnormal. So we saw him, we did the workup. We did not label him or find a clue towards the endocrine etiology of resistant hypertension. So we just called essential and then started making some adjustments. So once somebody is already on 6 or 7 drugs, then it's a matter of what their body likes, what they can tolerate, and what they respond to. So he was on good, essentially, some of those medication. I don't see amlodipine listed, and he had severe side effects. So he was also sensitive to some of the medication. So he tried almost various different medication in the same class, and also all the classes of medication for blood pressure we can think of, but not the minoxidil. So anyways, I think I saw him, we just made some adjustments. I bumped up his doxazosin. He actually noted some help, and then I introduced hydralazine. And, he thought that was the missing link. The hydralazine really worked like magic for him. This is the patient who really records all his blood pressure readings in a spreadsheet. So he had, everything like to the science. So he really responded well to the hydralazine. Blood pressure came down in 120s and 80s. And I gradually increased the hydralazine to, really where he tolerates. And then he also wanted to do twice a day medication rather once a day. Some of the medication we could cut and give him twice a day, because anytime his blood pressure drops below 120, he felt dizzy and lightheaded and didn't like it. So he wanted to be very tight control of the blood pressure. So we actually achieved within a few months, his blood pressure was optimally controlled. Over the years, I think this was now 2018, 2 years down the road, he came to me, he said, like, I have developed gynecomastia. He reported severe breast tenderness, and he was not happy about it. So we tried to lower his spironolactone first, and then I had to stop because his blood pressure remained well controlled on hydralazine. But he told me eplerenone was tried, and that caused severe headaches. And actually, he ended up in the hospital after taking eplerenone. He became dizzy, and his blood pressure shot up, not went down after taking eplerenone, which was quite counterintuitive. I did add amiloride as we stopped his spironolactone. And this was just, to keep him as one of the potassium-sparing diuretics. And hydralazine adjustment was really something that led to good control. So 2016, 2018, these were the changes. Now pandemic hit. So this is 2020, late 2020 visit. And I think some of the workup was done in 2021. He noted that blood pressure is inching up again. So I'm like, maybe we need to do some workup again. So I sent his endocrine workup, and this time his Aldo level came back 40 nanogram per deciliter. and his renin activity. The renin, it says renin, but this is plasma renin activity, PRA. This is 0.9 nanogram per milliliter per hour. And his metanephrines, norepinephrines were similar to what we did like 5 years prior to this testing done. So I pause here and ask us, like, what would you do next, or what do you think is going on? Maybe I can ask our experts to see what they think about it.
Okay, Irfan, go ahead. You are expert in renin and aldosterone.
Yep, that's the direction we are going. So
yes, I mean, I think there's a couple of points.
Okay, can I ask question one before you start?
Sure.
What was the side effects from amlodipine, and he was not studied on?
So there were side effects stronger than both amlodipine and the other CC.
Like edema or something else?
No, something more than edema. So he was not willing to take, so some intolerance, and I forgot, I might have to go back, but this was not just edema. Edema is considered as the, side effect, but he was more intolerance to amlodipine.
Okay, thank you.
So, there's a couple of observations I will make, and, this is not directly my field, but we all have dabbled in endocrine hypertension. The first thing is there's this construct, one of the things that is one of my pet peeves, and as one gets old, you start rolling your eyes on things that become your pet peeves. And one of my pet peeves is the word workup. That, okay, what is it that we need to do to exclude primary aldosteronism in any particular patient? And everybody would say, get a renin and get an aldosterone, and if it's less than 25 or less than 30, move on with life, right? So the construct that is presented to us always is that it's a categorical disease, right? There's a line that is drawn. If your numbers are on one side of the line, you have the disease. If your numbers, so I mean, when you're doing the ratio, is 24 different from 26? Is 22 different from 27? But the way it is presented to us is the ratio is below a certain number, we just forget about it. We say excluded primary aldosteronism, and that's it. That's the first point, that we have to start thinking about this disease as a continuum, as a spectrum, and these numbers help us in adjudicating certain buckets for them. And that is why I was asking for the aldosterone number and the renin number from the first test that you did. And I would bet a lot of money that if you looked at those numbers now, if you actually found them, the aldosterone would be like 15 or 12, and the plasma renin activity would be 0.4, 0.3, or 0.2. So whenever you start looking at these renin-independent hyperaldosteronism cases, we have to think about these differently, and we first have to identify the syndrome of primary aldosteronism, that the aldosterone level is abnormally high for the degree of hypertension in which the renin and aldosterone should both be suppressed, and the renin number, right? So that is one thing, and I don't know which way this case is going to go, although the numbers in red are very, very definitive now. That's a very abnormal number. But that's the first thing. The second point I would like to make as we are going through the evolution of this case is that, like all hormones, aldosterone and indeed renin is episodic. I mean, you can have a diurnal rhythm, you can have episodic release. So you can actually look at people who've had bona fide primary aldosteronism diagnosed and check their aldosterone ratios and aldosterone levels at different times of day and different occasions, and you'll see a fairly big variation in those numbers. So again, the message is, if you see one number that's like 15 and the plasma renin activity is 0.9 or 1, don't exclude the diagnosis or don't stop entertaining the diagnosis. Don't close your curiosity towards that diagnosis prematurely, because there may be that. And the third point I would like to make in this is that, especially in the United States, we have to be careful that many labs are switching the way they check aldosterone from immunoassays to LCMS. And when you check aldosterone with LCMS, your level is lower. So we might need to start rethinking about how we deal with these ratios if the numerator of that ratio is going to be lowered because of the methodology. So I'll just make these 3 points over here, and then we'll see how the case unfolds.
Excellent points. Avas, do you want to add something?
Yes, wonderful description of importance and how you take this level. So let's talk about a little bit of the medication effect on aldosterone and renin level. So when this test you did, at that time, patient was off spironolactone, or he was still on?
That is true. So this test patient off spironolactone for 2 or 3 years. He stopped all spironolactones, but he was on losartan, but spironolactone was stopped maybe 2 or 3 years prior to this test was done.
Okay, so let's talk about a little bit about the effect of spironolactone, or ACE inhibitor or ARBs on the renin level or aldosterone. So basically, ACE inhibitor or ARBs, they increase the renin level. So if patient is on those medication and renin level is still suppressed, that actually gives you a little more suspicion that patient might have primary hyperaldosteronism. So this patient has been on spironolactone, ARBs, and his renin level is still very low, and ratio is high, and aldosterone is high. So this looks like it's a case of primary hyperaldosteronism to me. The question is what to do from here. You have to do a confirmatory test. I think you are lucky that I think the bilateral adrenal vein sample. First of all, you have to do this like a CT scan or MRI just to see whether there is. I'm sure that is already done. So it was negative, I assume, or there was never needed because the aldosterone level was normal at that time. So I would start with, I will do whether there is a CT or CAT done, and is there any adenoma or not. If not, I think this patient with so much hypertension and very suspicion of having hyperaldosterone, particularly with all this medication, he is on multiple medication which can increase his renin level. He is diuretics and ARBs. So he, if you can, which I'm sure you have capability of having done that bilateral adrenal vein sampling, and that will give you a diagnostic test whether he has or not. My feeling is that he will end up having that.
Thank you.
So correct me, Avas, adrenal vein sampling is not a diagnostic test per se, right? It is more a localizing effort. So you've got, there's 2 or 3 things that could happen when we image this, right? We image this and you find a big nodule on one side and nothing on the other. You pretty much have the diagnosis you've got in
not necessarily. That's the thing. That's if you have less than 35-year-old, then you don't need to do adrenal vein sampling. If you're 60-year-old, you can have adenoma which is not active, and you can have more active gland on the other side, and you end up taking off the wrong adrenal gland. That's why the question is more than 35-year-old. Huh?
It's a localizing test.
It's localizing test. Yes.
It is.
Right. That's the point I was trying to make. It's not diagnostic, but it's actually localizing that which kidney or which adrenal the activity is actually coming from.
I know you can go 24-hour aldosterone level, potassium level, just more like saline infusion after that. But for me, this level by itself very put me in high suspicion. I would go, if possible, direct to adrenal vein sampling. I'm sure your university have this capability.
Thank you. I would say all excellent points. Understanding that this is a spectrum of disease, not an absolute disease. I think that was point very well taken. Understanding that your curiosity should not you should not settle if you don't get the answer based on one set of labs, because even the salt intake, activity level, medication, posture, that has an impact. Understanding that there is confusion about the test ratios, reliability, the units used, the picogram and nanogram and international units, and renin activity versus the renin concentration. So again, I think the clinical acumen, keeping that open is important. And I also believe that human bodies also change. The person who may have, as Dr. Aga mentioned, low levels a few years ago, things might have changed. So just to keep that in mind, because the patient remains on medication, we got control. Now for the last 6 months or a year, things are out of control, despite of the same medication and or with the additional medication.
So for management, for the time being, I have a comment. So basically, he, for some reason, could not tolerate calcium channel blocker. So he went to another vasodilator, hydralazine, and he was good. Now probably it's causing a tachyphylaxis, or that effect of the hydralazine is less now. I would put him on minoxidil, and with that you will cut down his pill burden a lot. I think so, with minoxidil, if you add that. And also, if patient is not a surgical candidate for whatever reason, obviously, then you don't need to do adrenal vein sampling even. So then you have to treat medically. And what choice you have? Patient could not tolerate spironolactone or epinephrine, or amyloid did not work. So maybe you can try that new medication, phenylalanine, on this patient. It might tolerate. I know it's a different indication, but I think if patient has hyperaldosteronism, that medication might be helpful for him.
So let's see what happens to the next. I think your points are well taken, and this is if the medical management has to be the mainstay. So we'll talk about phenylalanine in the end.
Good.
So there is an app actually, and Dr. Ali, this app is very important. Maybe you can. I just downloaded just now today, like maybe 30-40 minutes ago. You can see like 11:22. And the app was mentioned in a review article, which was just recently published a couple of years ago. So the app is just called, I think it's called, let me just, ARR, aldosterone to renin ratio app. So I entered 40 as the patient's PAC. I entered PRA, which is 0.9. I did not enter DRC. DRC is the direct renin concentration. The app actually calculated this for me because I only had potassium, PRA, and the ratio. So then I hit calculate, and this is what I get. So I get PAC, which is 40, and then it actually converted this into those picogram limits and pico, some other units, which I'm not very good at. And then it gave us the ARR, the aldosterone to renin ratio, 44.6. The cutoff is more than 26. It also gave us this ratio if you use actually the direct, concentration, which we did not use. And but the endocrine societies and folks have actually agreed to a basic minimum. So according to the app, the possibility of or probability of aldosterone high is 100%. So that was one discovery I made. So then the other tests which we did on the patient were the 24-hour urine aldo level, which came to 42 microgram in 24 hours. And I think you have to control it with the urine sodium to make sure that patient is not on a low salt diet, which can actually increase the aldo secretion. Again, there is some controversy about the cutoff for sodium. Is this 150, 200, or 300? But the concept is that if the urinary sodium is low, then the aldo can be physiologically high. So this was one of the nice infographic and connecting some of the dots. And this came in the Journal of American College of Cardiology. So they connected the dots, and a lot of research on the Aldo axis has been done to look for these. For example, finerenone, you mentioned, it not only helps with the renal outcome, it also helps with the cardiovascular outcome, because they focus on, you know, this endothelial dysfunction.
And he's diabetic with the microalbuminuria.
Yes. So you can see that three outcome. One is the AFib, one is that how it can lead to MI, heart failure, and high blood pressure. So one is the volume axis. So your volume is high, your preload is up. You can see the changes in the heart with hypertrophy, fibrosis, dilatation. It can lead to AFib. Hypokalemia itself, you know, hyperaldo is a state that promotes, asks the ROMK in the kidney to pump out all the potassium out. Because ENaC is super active, and then that can also cause arrhythmia in the heart. You can see that the Aldo, when the Aldo states are high, there is endothelial dysfunction, vascular remodeling. So things not only occurring on the heart, but also on the vessels. And then, so some of the downstream impact on the heart, vessels, and blood pressure were mentioned. This is one of the approach from the same article about this algorithm is like, you know, you do ARR when you have high blood pressure patients who have more like higher probability of PA is primary aldosteronism. And then I think they also want to make sure that you consider this in the context of the 24-hour urinary excretion and serum potassium to make sure that you are getting the clue towards the right. In there, I think they used a ratio like a spectrum normal, which is less than 20 nanogram / MIU. So PA is unlikely. In the middle is kind of the gray zone, and on the right-hand side, more than 45 when you are more certain. And the next step is the CT scan. And then also to look for what's the approach, surgical or medical. Then adrenal vein sampling at that point helps whether this is if it is a bilateral problem, then you focus mainly on the medical treatment. If this is single unilateral, then surgical treatment is one of the option. In the same article, they mentioned some primary aldosteronism are surgically not curable, like if you have bilateral adrenal hyperplasia. So unilateral, go ahead. So you have unilateral aldosterone producing adenoma with bilateral like adrenal hyperplasia. You have some sort of type 1, type 2, and type 4, those syndromes. So they are surgically not curable, but where the surgery might be impactful, one is the aldosterone producing adenoma, unilateral or bilateral. Primary multinodular unilateral adrenocortical hyperplasia, ovary aldosterone secreting tumor, if there is concomitant pheochromocytoma, or aldosterone producing carcinoma. So we did CAT scan for our patient, and it showed that on the left side, so this is important, left side, there was lipid rich adenoma, which is 1.3 to 1.1 centimeter or 13 to 11 millimeter. And there was bilateral gland thickening as well, likely secondary to hyperplasia. And then there was a small stone on one side of the kidney as well. So adenoma is on the left side. There is bilateral thickening as well. Next, we did the adrenal vein sampling. So this is the letter I received from the person who actually did the adrenal vein sampling. So I removed some of the, the demographic information. So it's interesting that if you see that the right side Aldo level was 4,880, the left side, the level was 146. So there was similar trend when they checked the cortisol. Cortisol was more than 1,000 on the right side. Adenoma was on the left side, but right side is which is, sending all the juices in the system. And when they do the test, they test this under constant infusion of ACTH. So they really stimulate the gland to churn this and see what if there is lateralization or not. And then they did this in the IVC as well, where you can see that in the end, kind of it's not too high. So, but you can clearly see that right side, there was lateralization. So he also mentioned the word dramatic lateralization to the right, opposite to the side of the mass. So the left-sided adenoma was considered to be non-functioning, and then the right-sided hyperplasia. So the proceduralist thought that the patient should undergo the right adrenalectomy. And I think they just mentioned about some of the same safeguards they use, and the test came back. So the next thing we discussed with the patient. He really wanted this thing to be done. He looked at some of the data himself. He's now 69. So this is the letter that I received from surgeon. And then it just mentions things like CT showed left-sided lesion, biochemical evidence of primary hyperaldo, vein sampling showed strong lateralization to the right. So patient, so they actually, he did surgery right before, like in December of 2021. There were multiple lesions in the adrenal on the cross inspection, and the final pathology showed adrenocortical adenoma. So patient did well. So we did this testing a month or two after the surgery was done. So his aldo level came down to 7.8. It was 40 before, and renin level is 0.5. I didn't calculate the ratio, but you can see that there was improvement in the numbers. But what actually happened to the patient was, let me stop share and then I can keep updating patient score. So patient seen dramatic improvement in his blood pressure control. And it's not that, so the number of medications were reduced and the doses of some of the medication were also lowered down, but other things he noted that his sleep improved. He was sleeping better. The diastolic blood pressure remained consistently below 90 all the times. Systolic blood pressure sometimes inched up to 140, 150, but then he had some mechanism to manage that. And patient, we have one happy patient in the end who is now with the controlled blood pressure with slightly lower number and doses of the medication, and he's seeing some of the other benefits. His creatinine remains normal throughout. His albumin urea on the most recent testing is 0. His is completely gone, both protein to creatinine ratio as well as the albumin to creatinine ratio. I did put him on SGLT2 inhibitor recently, not the finerenone. I thought that finerenone is clearly, is not approved for this indication as of yet, and it would be difficult for me to get that approved. But he is one happy patient with good blood pressure control, and after the surgery is completed. So I stop here. We can take any questions, and then this is open for discussion.
Okay, let me just a comment, not a question. I mean, over the years, I have been seen or been presented many cases of like hyperaldosteronism. I mean, this is one of the best prepared from your part. You've got the history, you got everything, level, CAT scan report, and happy ending. So I'm really, really happy that I'm part of this discussion. Thank you very much for presenting this and giving us all the details. And so very, very, very nice presentation. Very happy to be here.
Thank you, Dr. Masood.
Looks like you made Aves's day. He's visibly beaming. He's happy. That's good.
No, this is thing that you have to do adrenal vein sampling. Even doesn't matter after 35-year age or 40 years. If you have adrenal, this is a precise example that you cannot take a wrong gland out. This adenoma was on the other side. The hyperactive gland was on the other side. Wonderful case.
Absolutely, absolutely.
Thank you.
So
no question. There's no questions in the chat, but again, it is very, very, very important that we understand. So even in that diagram that you showed, which shows that if there's a ratio less than 20, I think, PA is unlikely. I think it is algorithms like that that are actually forcing nephrologists as well as, or leading nephrologists as well as endocrinologists to underdiagnose a functional aldosterone state. So there's two or three things that we must always remember. The first is the hyperaldosteronism that we are talking about is a renin-independent hyperaldosteronism. So if you're dry, like Avas said, if you've got somebody on diuretics, their renin levels are going to go up and the aldosterone level is going to go up. And so you're looking at cases where the renin is suppressed, the aldosterone is high. And almost all of this data stems from earlier papers, and they drew a line pretty arbitrarily around 12 or 13 nanograms per liter of aldosterone a day. And I may be wrong on the units, but the number is 12 or 10 or something like that. That anything above than that is abnormal. Anything below that is normal. But when you look at data, even in normotensive patients, in mildly hypertensive patients, and then especially in patients with resistant hypertension, the levels of aldosterone creep up. And at worst, if you're going to consider this, you have a target. At best, you may have a disease. So like in this particular patient, if we had looked at that, so the aldosterone number, which is normal, maybe 14, the renin number, which is normal, maybe 0.4 or 0.5, and the ratio would be below the 30 threshold. So we would say the renin, the aldosterone, and the ratio are all normal. But what then happens is what we are looking at is a person with a relatively high aldosterone level, and in the face of suppressed renin activity. And what they had at that time was the hyperplasia. And then in the right genetic milieu, if there's a particular types or series of mutations, some people in this circumstance develop adenomas, and some people can very rarely develop carcinomas as well. So once you have the syndrome of primary hyperaldosteronism, the first thing is, okay, they've got more aldosterone than they need. Then the second question is there an adenoma? And the third question is what Wes was answering was, should we take something out? And when we start thinking about taking something out, we have to figure out which side to take out. And so only, when you've got laterality determined, you say, okay, this is where we're going to go. So in this particular situation, the laterality leaned towards the hyperplastic gland, not the gland with the apparent dud adenoma. So that's I think not the breach, but the rule that we miss a lot of PAs. And the reason we miss a lot of PAs is because a lot of our societies, renal as well as endocrine, are pushing forward these cutoffs. And so what we do is we say, okay, we've looked at the number, the cutoff it's below the cutoff, therefore the disease does not exist. And that, I think, is a disservice to a lot of our patients.
So let's see the situation in Pakistan. Do they have this capability of having adrenal vein sampling, or they do not?
Let me ask Dr. Zahid Beg, because he may have better resources at CMH. Ali, you want actually Dr. Zahid first, and then Ali, I saw your hand.
Thank you very much. No, not to my knowledge. I don't think so that we are having this adrenal vein sampling here.
Yeah, it's not available in even here, even my hospital. It's not available. I have to send to Penn, which is close by. So it's very precisely, I mean, I've done here, but I was not very happy. So I still sending to close by bigger place. So if this patient was in Pakistan and what would you do when you don't have this capability of adrenal vein sampling? So, I mean, the younger patient, even I have here, I don't send them for adrenal vein sampling if it's somebody 30-year-old and he has a hyperaldosteronism and there's an adenoma on one side. So it's not recommended that you have to have adrenal vein sampling. I mean, you can if you, but otherwise, more than likely that that tumor is causing the hyperaldosteronism. When elderly patient like this, elderly mean that older, 60 or older or more than 50, then you have problem. So
especially when you're looking at the CT and there's hyperplasia visible. So
yeah, so I don't know, in the older patient, if you don't have that capability, you go ahead, do the surgery or just treat medically. That's the question.
And I see Dr. Ali Ashraf, he had his hand up too. Is he still on? Maybe his dropped from.
Dr. Lainwala is trying to speak, but
Yes.
I think he's
Yes.
yeah, we can hear you now.
These adrenal vein samplings are very tricky for at SIUT also. I think the main problem is the understanding. What Dr. Aga was just explaining, how I mean, it has opened my eyes too, that all these normal looking renin and aldosterone levels are just we just ignore them by saying that they are still within normal limits, and we go by all these fixed criteria of that the ratio was also normal, and then we stop looking at it. But it's just these I think it's lack of this understanding that we have not developed expertise to do these adrenal vein samplings. So yes, now I can think back that there are quite a few patients who would benefit more if we do these tests rather than just taking these adrenals out, or then we rely on these nuclear scannings, and if we don't see real adenomas, then we just continue with our antihypertensives and don't think again. So yes, we don't have this expertise, and it can be developed only if we know this whole syndrome in a more better way.
There's a question on chat. So Avas, get ready for this. The question is from Dr. Hina Aram, and she asks, sir, if this patient had hypoaldosteronism secondary to adenoma, why this patient's blood pressure initially responded well to hydralazine in 2016? So Avas?
I mean, basically, he was not only just on hydralazine, he was on other medication also, which were actually helping this patient from hyperaldosteronism. Like he was on spironolactone all the way, and he was on ARBs also. But again, needs a little bit more vasodilation. I mean, all the resistant hypertension patients, all of them, you cannot control the blood pressure without vasodilation, without vasodility, either on amlodipine or calcium channel blocker or hydralazine or minoxidil. You have to have it. Okay, so this patient was not on that, and the moment he had that, and hydralazine pretty strong vasodilator, so that's why he responded to that. So that's my. I think that's what happened. Vasodilation. I mean, you cannot treat a patient with resistant hypertension without a vasodilator, whatever the cause is.
Dr. Hafiz Mahmood. Dr. Mahmood, you're next. You're still on mute.
So other thing that I want to comment on that lack of availability of resources for adrenal vein sampling. I mean, obviously managing for these cases for a long time, and believe me, these are most satisfactory result, and patients are so happy. Like a couple of patients of mine, they actually, more than a couple, but they cured completely. They are not on medication. A couple of them, they still keep coming to me. I say, you don't need to come to me. They just come every 6 months. We just want to make sure we are okay. The other thing that I have done, many patients who I was not able to do adrenal vein sampling because of insurance or whatever reason, and went ahead with the obvious adenoma, and luckily everything was fine. That was the culprit site. So, I mean, I think you cannot be 100% sure without that capability, but if you are sure that patient has hyperaldosteronism and the adenoma is pretty significant, I think you should go ahead, take chances. More 90% time, it's rare that you have cases. What Dr. Farooq presented is rare. It's not like a common that you have the other side more active than the adenoma. Irfan, what do you think?
Well, I think if imaging sometimes helps in these cases, and I think if you don't have adrenal vein sampling, then you have to make the best guess. Again, if your CT is clean and all you have is an adenoma, and like you said, if it's a younger patient, I'd roll the dice. If it's an older patient and you're seeing hyperplasia, then rolling the dice may be
You cannot
difficult.
see hyperplasia by CAT scan if you like CAT
No,
scan.
I mean the thing is, if you're, I mean, in this particular case, the CT was reporting hyperplasia and nodules, right? So you can actually tell that the adrenal is a
Some
little
thickening, yes.
abnormal. Usually, sometimes when I'm trying to think through this, I get an adrenal MRI. There's a specific protocol for adrenal MRIs. They call it an in-phase, out-of-phase adrenal MRI. It's done without the need for gadolinium, and it sometimes gives you a very good resolution of the adrenals themselves. But again, that's a first world problem of which imaging modality to use. In Pakistan, I think the question is, which can you get? And then it depends on how well they do that CT scan and what resolution they're getting and how good the radiologist is, because this is an experience requiring domain. So somebody who knows what they're doing. I mean, even in our CT departments, there's one guy who I read adrenal CTs, and so they're better at it than everybody else. But the thing is, from time to time you may run into a ditch, but 9 times out of 10 you're probably gonna be okay. And that's a little bit of a risk that you take when you're rolling the dice without vein sampling. So we all get vein. I mean, I've never taken an adrenal out in a person like this without doing vein sampling. But if I had a 40-year-old guy with a 4 centimeters, 3 centimeters adenoma on one side, everything else looks good and clear-cut primary aldosteronism, I'll probably take it out.
Thank you. I think we have two. Dr. Lainwala, Dr. Mahmood
Yes,
actually raised his hand before you. Can I invite him for, and then
Sure.
you, and then Dr. Ali Ashraf, who seems to come back to the Zoom room. Dr. Mahmood, you are next. Okay, so he was probably out of the. He has two connections running.
I think he may be having issues with his
Technical.
audience. He's probably dialed in. So I just let him back into the chat. So maybe he'll be able to speak now.
Hi, can I ask a question? Yeah.
Please go ahead. We can hear you now. Go ahead.
Yeah. So the question is, I have experienced there is a patient of mine who has there is there are lab evidence, hypokalemia, metabolic alkalosis, and high blood pressure, which is fairly controlled on several medications. I can't remember the whole list, but it's controlled, and he's hesitant to go for any surgery. He says that he wants just medical management. His age would be around 60, close to 60. So since he never wanted any surgical procedure, so I did not proceed further as well, with repeating his like aldosterone levels and renin concentration or aldosterone to renin ratio. So, but he's on like ARBs, he's on spironolactone and amlodipine as well, different blood pressure medications. My question is like, if I need to go ahead and do his labs, should I like, stop the, I mean, not, I know I have to stop it for the test to be valid, but in case if his blood pressure is not allowing me to stop it for transiently, like especially spironolactone, can I still do the test? And maybe that information will be somewhat useful, in determining whether he has actually primary aldosteronism.
Okay, should I take it?
Yeah.
Okay, so let's see. First of all, if this patient is not willing to go ahead with surgery, I mean, you're doing the right thing, you're treating medically. Okay, you do the, most of the time you do the workup when you think that you can fix that patient found to have primary hyperaldosteronism, and some surgery is an option. If patient is not willing for surgery or is not candidate for surgery, you don't need to do too much workup. You can just go ahead and treat medically. The other thing that if patient is on these medication, and most of the patient you cannot take the medication off because the blood pressure is so high, you're worried that if I take the blood pressure some medication off, the blood pressure will go high, and that's not good. So only question come when patient is on spironolactone and you want to see whether I should take. That is the medication which affects the result most than other medication. If patient is not on spironolactone, you can go ahead and it will not affect much your outcome. But if patient is on spironolactone, but patient, what it does, spironolactone increase your renin level, okay, and also increase your aldosterone level. So, but if patient already has hypokalemia a lot, and the patient is on spironolactone, that means that because of spironolactone, that receptor is not blocked. If patient has spironolactone renin level is high, then you are kind of stuck that this because of spironolactone, the renin level is high, or because of if patient is on spironolactone and your renin level is still suppressed, that tells you that most likely this patient has hyperaldosteronism. So that's my take is. But ideally, after that, you have to find some way to take the patient. If you want to confirm that, you have to some way to confirm if patient is the renin level is high, you have to take the patient out of spironolactone if you want to really diagnostic for 6 weeks and then do the test again. If the renin level is low, then pretty much it looks like that is as he has primary hyperaldosteronism even on spironolactone.
Thank you. Dr. Lenwala, it's your turn now. Sorry.
Yes, I had a query. I had a query on Dr. West's comment on hydralazine when he said that hydralazine is a good vasodilator. In my experience and in my readings also, I think hydralazine, if anything, is a very mild vasodilator. And the problem with hydralazine is that almost all the drug interactions that we read about are true for hydralazine. It interacts with almost everything. All the drug-induced lupus and everything, hydralazine comes first. And the thing is that it has to be taken 3 times a day in most cases for it to be effective. So as a chronic medicine, as an antihypertensive, it is really very difficult to take, to be compliant with it. So
Absolutely.
I don't know. For me,
if you have seen my previous lecture, I hate one drug most and I hate to use it. And I told them to not to use it. But number one was hydralazine. For the same reason what you told. And I was kind of surprised that from the Dr. Omar's case that this patient, but the patient are different. They don't need medicine. That's the problem with the patient. And patient did respond and he tried and there's nothing wrong with that. And that medication work. But absolutely right. Hydralazine has not even tier 1, 2, 3, 4, not a blood pressure medication from the same reason what you told.
Allow me to respond. My personal, it's all data free zone
In
now.
this situation, you have to start with Millard. So
Okay, Milord, this is what I would like to submit, that I believe that everybody with resistant hypertension, there is one magic drug that they respond better than some of the other cocktail of the drugs. And sometimes once you discover that magic drug, then you can really focus on that. And Milord, for this particular patient, hydralazine was the magic missing in the cocktail. The moment I added, patient called me, he said, this is something I've been missing. Thank you very much. And then we maintained him from 2016. I mean, he just had surgery done in 2021. We maintained his blood pressure pretty reasonable, maybe 4 out of the 5 years with the medical cocktail we use. And hydralazine was his magic drug. So I stop here. I know Irfan wants to say something.
Umar, just one quick comment, and then there's a couple of people I would like to go to. The question is, when was the aldactone started on this patient?
Aldactone, he came to me on aldactone. So some
Poorly
maybe
controlled on aldactone, you
2006.
added the hydralazine and he did better.
Yes.
I mean, the one
And
thing
then-
that comment is on spironolactone is that most of the time, almost I've seen 80% time, we don't give enough dose for spironolactone. I've seen people taking, 50 milligram, that's it. I have a patient who is on 200 and 300 of spironolactone dose. I have a patient who on medical treatment for hyperaldosteronism, like 50 or even 100 is not enough.
And that's an excellent point, Avas, because I think we sometimes look at spironolactone in hypertension, we say 25 milligrams, 50 milligrams. But when you're trying to suppress PA, you need to go much higher. Similarly, the equivalent doses of eplerenone are much higher. So I also see there's somebody when they stop spironolactone, they start 50 of eplerenone, which is nearly not enough and wouldn't work. Now, that's a very, very important practical point, that if you've got somebody like Dr. Mahmood's patient who you were forced to treat medically with diagnosed primary aldosteronism, you have to go on a much higher dose of spironolactone. 25 or 50 is not going to cut it. Okay, so I've got a question. This is for you, Umar. Dr. Naila Asif wants to know why finerenone was not tried. It is more potent in blocking the mineralocorticoid receptor.
Yep. So I can respond that, and then we can go to Dr. Farooq Islam. So finerenone is the newer non-steroidal MR blocker. So this is the antagonist, but this is non-steroidal. So that is one of their they're selling this drug like this is non-steroidal and does not come with those steroidal side effects, which we saw in my patient, like gynecomastia in men, dysfunctional uterine bleeding in women. The finerenone got approved by FDA either April 2020 or maybe later, so sometimes in 2020. So it's a recent FDA-approved drug. Finerenone is not approved for resistant hypertension or hypertension at all as of now. It is more potent and it is more specific, and it binds the receptor rather, more avidly than spironolactone and eplerenone. But the indications this is approved, those are completely different. In the actual trial, the Figaro trial and the Fidelio, you can see that hypotension is listed as a side effect. So there are 3 side effects which are listed in the trial by the finerenone. One is hyperkalemia, second, which is 18%. Second is hyponatremia, which is 9%. Third is hypotension, which is 3% of the patients. And the drop in blood pressure was anywhere between 3 to 5 millimeters of mercury. I wish if finerenone had a potent impact on the blood pressure control. Yes, this is a better drug in blocking the mineralocorticoid receptor. So eplerenone is approved for different indications than even spironolactone has the wider FDA approval for indication, including congestive heart failure, resistant hypertension, eplerenone, narrow spectrum, finerenone, the narrowest spectrum for diabetic nephropathy, proteinuria reduction, CKD progression, like a 1/5 reduction of renal outcomes, and also roughly 1/5 to 6th reduction of cardiovascular outcomes. So that is not the drug approved for resistant hypertension or used for resistant hypertension as of yet.
Yes, absolutely. There's no head-to-head trial, but general feeling is that finerenone is not very potent antihypertensive medication compared to spironolactone.
Okay. And we had somebody had their hand up if they want to join the conversation.
Yeah, I think we lost them.
Yeah, I'm Dr. Farooq Islam. I'm doing practicing nephrologist at Multan. And I have got a patient, a young patient. It's not actually a resistant case of resistant hypertension, but it's a case of hypertension in a young 16-year-old gentleman, 16-year-old boy rather. And I wanted to get some your input and some guidance on how to go ahead. Can you hear me?
Yes, we do. Please.
Can you hear me, please?
We do.
Okay,
We hear you. There is some interruption.
So he's a 16 years old. Yeah, I think there's some internet connection problem, but I'll try to go ahead with my case. That he's a young boy, 16 years old, who is a student in a cadet college. And he came to me with a new onset of hypertension with blood pressure of 160 by 105. He's normal looking with BMI of around 20. And his blood pressure, as I told you, rest of the physical examination was unremarkable. There was no renal bruit. There was thyroid was not enlarged, and there was no radiofemoral delay. So there was no any positive finding on his physical examination. When I did some investigations, his RFTs were normal, urea, creatinine were all within normal limits. His protein creatinine ratio was also within normal limits. Ultrasound, kidneys ultrasound was also within normal limits. His Doppler renal limits, thyroid functions, liver function test, CBC, all that were they were within the normal limits. His potassium was 4, and ABGs showed mild metabolic acidosis with bicarb of 17.7, HB of 7.31. So normal potassium levels with mild metabolic acidosis. On endocrine screening, I did his 24-hour urinary metanephrine, which is because it is only available here. That came out to be within normal limits. Serum aldosterone levels were done, and they were 6.6 nanograms per deciliter. That was within normal limit. Plasma renin concentration was done. That was 28.1 micro international units per ml. And I just used your ARR app, and that the ratio was within 20 to 25. So aldosterone levels, renin levels, they were also found to be within normal limits. So I don't have any clue that why is hypertensive at this young age. His family history is unremarkable. His parents are all within, they don't have any positive history. His siblings are all normal. So I just wanted to get your input and how to go ahead with this patient. The good thing is that his blood pressure is well controlled on just 2 drugs, that is amlodipine and valsartan. 5 milligrams of amlodipine and 80 milligrams of valsartan, and his blood pressure is now 140/90. And I am treating him for last almost 2 months now. Just I wanted to have your guidelines how to go ahead, because whatever I have got in this area, I have all exhausted with the investigations I have got, but I don't have any clue why is he hypertensive. So thank you very much.
So what's his blood pressure now?
He said
140/90
with just 2 drugs.
So that's not controlled. I mean, this is way higher than what you'd like to aim in this 16-year-old.
Yeah, it is, but compared to previous one that was 160 by 105 when he reported to me. Now I still have got some margin in increasing the doses, but I hope that it will be controlled if I just increase the amlodipine or valsartan.
Okay, so, okay, anybody want to go ahead or should I?
Please go ahead, Dr. Masood.
Okay, so you already done enough, I mean, a lot of diagnostic tests, and I think that we don't need to do more. I think I mean, again, we don't know why he has, but again, what I look at into it is, how is the potassium has been normal or high side or low side, how it has been?
His potassium is 4 milliequivalents per liter.
Okay.
It's 4 milliequivalents.
So it is normal. Okay, fine. So basically, I don't know. I mean, if patient has metabolic acidosis, okay, and a young patient, I mean, patient most likely has some congenital or inherited disorder. We don't know, and we probably will never know. So my approach is that if patient comes with the metabolic acidosis, the most effective medication for them is thiazide diuretics, okay? And the patient comes with metabolic alkalosis, like more like a hyperaldosteronism, I mean, then spironolactone, those medications are more effective. So I would add this patient. I mean, he's like a kind of maybe something like Gordon syndrome, thing like this, but you cannot prove that. So I would add definitely this patient thiazide diuretics. And he's very young, and you would like to keep his blood pressure low. I mean, the goal should be less than 130 systolic and diastolic also less than 80. This is, you achieved a lot, but you have where to go. You want to bring it down. So I would put him on hydrochlorothiazide. This young patient, they respond pretty good to ARB's ACE inhibitor. I would increase the dose of valsartan. He's on if blood pressure is not enough control, but definitely my goal would be to bring it down further.
Okay, thank you. Thank you very much.
Swan, what do you think? I mean, no, you're not a pediatric, we are not either, but anybody else from Pakistan, they have experience of dealing with pediatric hypertension? I don't have much.
Yeah, I think I was thinking to ask Dr. Lanewala to guide us on this patient as well.
Well, this is now becoming routine in seeing essential hypertension in adolescents. I was surprised to hear the BMI of 20. Usually they are obese children. And I heard that he got admission in cadet college. So his physical activity is also high. So that is not the usual typical adolescent, hypertensive adolescent that we see. There are few other syndromes that we commonly we want to rule them out as because Marfan syndrome has it has a lot of varieties, and so if he has like long limbs and is like limb to this thorax abdomen, the trunk limb to trunk ratio. It's just by the look that you can tell that, you know, they have these longer limbs. And if it's not, and I would just probably add one 2D echo to make sure that, you know, he does not have any congenital coarctation or, and those blood pressures have been checked on all 4 limbs. And if they are normal, then yes, we just like Dr. Masood has elaborated it very well, that yes, adding some thiazide diuretic. And now we have these combination pills of amlodipine, valsartan, and thiazide in one pill and in different denominations. So just one pill for this young man would be enough to, you know, would be a good medicine that he can take for a long time.
Should we look for any cause of RTA on this patient and why he has metabolic acidosis?
Well, usually RTAs are other than the Gordon and the other one, there's another syndrome that
Barter.
No, they are usually Barters
hypotensive.
are usually normotensives.
Or
There are only two tubular disorders that are
Little syndrome.
Little man.
Little syndrome.
no, little would cause a high. Yeah, you're right.
But will have an abnormal potassium also, right?
Yeah.
But other than that, usually these congenital tubulopathies are so difficult to diagnose,
Very difficult.
and
Exactly.
I use them as diagnosis of exclusion. So if
Absolutely.
you don't find anything else, so you just take them as it is.
I agree. The only thing that because he's a cadet and weather is hot there, when you put on thiazide diuretics, make sure you keep checking his electrolytes periodically.
Yes.
But
And as our Asians, we are more sensitive to thiazide than the Caucasians and blacks. We tend to develop hyponatremia more often with hydrochlorothiazide than them, and that has been tried out. I don't know if there's any published work on this, but if you ask most of us nephrologists here, we see more often very severe hyponatremia with thiazide in our population as compared to others in our experience.
so, yeah, I would just go low dose thyroid, but increase the valsartan. ARBs will be very effective medication for him. I will go to maximum dose on that first.
Yes, 10/160 probably.
I mean, even 320 is we commonly give that, so
Yeah,
need to be.
agree.
Okay, although his body habitus is within normal limits, but I'll further check it out for marfanite features. And his potassium is normal, so that's why I didn't work up for the RTS, but I think I should do it. So that is one of the things.
Thiazide diuretics actually improve your metabolic acidosis also. That's the other advantage of giving thiazide.
Right. And your ARR app is very useful. Thank you very much.
Oh, that's
Because
great. I didn't know that. So
that talk, I just downloaded it and I just put it on my patient's parameters, and it came out to be very helpful for this patient. Thank you very much. Thank you.
That's wonderful.
I shared the link of the article which suggested about the app, and it was a lot of thought-provoking after the recent discussion we had since previous session about the variability of and different units used. So sometimes the saying is that work smart, not hard. So if app can help you, I'll take it any day.
So another question. Are you taking the question from the chat group?
There is a question about, I think it's about the medication and the.
Yeah, it's a more important question. I mean, you want me to talk a little bit about that?
Sure. I think the link will address that too, but of course, we want to hear from you.
Okay, then let me just briefly say that. Okay, so the question is, what medication should be absolutely off, and for how long before doing ARP? So basically, most of the time, we only medication which is cause problem and is spironolactone. Okay, all other medication we do not discontinue any of those because it's hard to, and you can interpret the results with these medications on. But if you have a patient is not very hypertensive, you can take off medication. So the medication which increase or decrease the renin level, you want to take them off. For example, ARBs or ACE inhibitor increase your renin level. So if you can take them off and put other medication, that's better. Beta blocker decrease your renin level. If you can take off renin, beta blocker if patient is on, that's better. Okay, and put patient on non-dihydropyridine calcium channel blocker like verapamil or cardizem if you can. Doxazocin also very low effect on renin and aldosterone level. Calcium channel blocker like amlodipine also does to some extent, but not much. So basically, if you want to keep patient on calcium channel blocker or doxazocin, these medication will least affect your level, and you want to put patient on if you can afford that. Take them away from any diuretics or ARBs with ACE inhibitor.
Thank you.
I had one quick question for Dr. Farooq Islam. The PRC that you have, what was the units on that? I'm just trying to figure out on your, and what was the normal on that test? Do you have that by any chance?
Yeah, I have got this. Just I'll look at it. I'll tell you.
You can put it in the chat. We can continue the conversation. I just wanted to take a look at what the units were being reported as.
Aldosterone levels were 6.6 ng per deciliter, nanogram per deciliter, and vanillin concentration was 28.1 micro international units per ml.
Gotcha.
So that's the direct renin concentration DRC.
Yeah.
And what's the normal on that test for your lab?
I don't have the values of the normal range, but I just wrote it on my notebook that it was within the normal limits.
Yeah, normal is around 32, 30 to 32. So it's kind of in that range or suppressed. Okay.
I mean, now you have the app, but generally you have to have whatever ratio is, you have to have certain high level of aldosterone to diagnose case patient of primary hyperaldosteronism. There's many factors which can suppress the renin and can increase the ratio. But to have primary hyperaldosteronism, you have to have something 15 or 20 in this range. So if you have 6, whatever the ratio is, I think it's very unlikely that patient has a primary hyperaldosteronism.
No, the reason I was asking about the PRC was to kind of see what the renin levels were themselves. So I think you and I are old enough to remember a guy by the name of Larag, who published in the 1990s a whole series of articles on how to approach management of essential hypertension based on renin profile. So if you have not read that, you'll enjoy reading that. So there's a whole scheme that it's called the Larag way of managing. I'll try to put one of his articles in our chat, in our WhatsApp chat group. And essentially what he does is he develops a scheme of introducing various medicines based on the renin profile. So most of, there were somebody's putting in Larag's lessons in hypertension, and I think that might be more accurate. And so essentially, when we think about hypertension, if you step back a little bit, and I'm talking about essential hypertension, when you step back a little bit, it's either a volume issue or a tone issue, right? So he kind of breaks them down based on that, based on the renin activity. If the volume is up, renin would be suppressed. If the volume is down and the tone is up, renin would be higher. And so there's this whole methodology that he developed. And that's why I was figuring it out, especially in younger people, in people with hypertension that you're diagnosing for the first time. It actually gives you some rationale of selecting a particular agent at a particular time, rather than going by, my first drug is always going to be a thiazide diuretic, which may or may not be the right thing to do based on that profile. So I don't think that this patient that Dr. Islam presented has primary aldosteronism. I agree that 6.6 is a very low number. So no matter what the ratio, I wouldn't get too psyched by it. But again, there are other ways to parse some of these profiles. So that's why I was asking.
Thank you. Any closing comments or any final questions by anybody?
Hey, Assalamu alaikum.
Walaikum assalam.
Yeah, I have a couple of questions about, just general question about resistant hypertension. This is Dr. Ali Asher from Multan, Pakistan. In my clinical experience, I found that amlodipine, in resistance hypertension doesn't work as well. Instead, if I give like nifedipine long-acting, which is Adalat CC, versus Herbesser, which is diltiazem CC, they work better. And they have the additional side effect or a better effect that they do not cause tachycardia. So what is your thought on that?
Okay, Basically, diltiazem and verapamil, this is non-dihydropyridine calcium channel blocker. They have, you can say that they are not considered as a first, second, or third line therapy medication. Your experience is different. When you have nifedipine and amlodipine, there's not much different. Nifedipine is and amlodipine is same, long-acting. Nifedipine is slightly a little more shorter acting, but not much difference. Once a day is given. So this is again these patients. I mean, you are telling your experience in more than one patient or one particular patient that diltiazem is more effective than nifedipine.
So my, whenever I get a patient that I put on amlodipine, again, the maximum dose, 10 milligrams, they usually have more constipation side effect, as well as, at least a couple of my patients had tachycardia side effect as well, which is not really, I've seen that with amlodipine. But when I changed that to Herbesser, he was actually well controlled, better controlled, and his tachycardia also kind of settled down.
Which is the other medication? What is the generic for that?
Herbesser is diltiazem, long-acting diltiazem.
Okay. I mean, obviously, diltiazem will not cause tachycardia; it can cause bradycardia. So different patient can have different effect. But other thing that my last presentation, I presented a slide where a study showed that dual calcium channel blocker, patient on both like non-dihydropyridine and dihydropyridine like nifedipine and diltiazem or verapamil. They're safe and they're effective, and the side effects wise, the constipation was more on the patient who were on diltiazem or verapamil. When they added nifedipine or amlodipine, the incidence of constipation was less. So otherwise, I mean, the constipation is a common side effect, but beta blocker and diltiazem, verapamil cause more constipation. So, I mean, again, that's why we learn from experience. I mean, your experience is not generally we see in our experience, but again, that's my comment.
Dr. Abbas, the most common problem we are facing with the amlodipine is the peripheral edema.
Yes. So that's also
yes. In my patients, yes, that is the problem. Then we have to shift to the diltiazem or any other drugs. That is the problem we have faced.
I mean, I put in the last time a slide also the mechanism of the edema caused by calcium channel blocker amlodipine. So how to treat that, how to minimize that. You cannot treat that. Basically, is that definitely multiple studies shown that is that if you add ACE inhibitor or ARBs with that, you can minimize or lower the side effects of edema. The way it works that when you give calcium channel blocker, you have arterial dilation, and there's no venodilation. So more blood flow go to the venules, the veins, and veins are still constricted, and there's more pressure, and that fluid peels off. I mean, cause the edema. But if you add ACE inhibitor or ARBs, you can cause venodilation also at the same time. And that's why there will not be increased venous pressure, and they will be less likely to cause spilling of fluid to the interstitial fluid because of that. So my experience is that women get edema more commonly than men at lower dose. At 5 milligram, very few people have edema, but again, some women get that, men also, but less likely. At 10 milligram, it's more common. But if you add ACE inhibitor ARBs, you will have less likely. And some patients, you have to tell them that this is the most effective blood pressure medication out of all you're taking, and this is not something damaging your heart or anything. If you have mild edema, you have to live with that. Some women come to me, oh, I have a little bit of ankle swelling, I got new shoes and I cannot put it on. So those kind of things, you tell them that you have to live with that.
सर एक्चुअली हमारे यहाँ यह है कि जिसके पाँव सूजे होते हैं ना, उसको गुर्दे का प्रॉब्लम होता है. तो जैसे हम एम्लोडिपिन देते हैं, वो नॉर्मल भी आते हैं ना, तो वो कहते हैं डॉक्टर साहब मुझे तो गुर्दे का प्रॉब्लम हो गया, मैं तो गुर्दे के इलाज के लिए आया था. तो अब ये है कि मेरे पाँव सूज गए हैं, मोहल्ले वाले भी कह रहे हैं मेरे गुर्दे खराब हो गए. दैट इज द प्रॉब्लम वी आर फेसिंग सर.
Yeah, I mean, make sure that they are taking low salt diet and cut down the dose of amlodipine. Some you have to take off, but again, some people they do mistake and changing from amlodipine to hydralazine. Okay, I've seen our cardiology friend, they do frequently. Hydralazine causes even more edema. than
I
amlodipine.
usually change to Laradip. I could not remember the name now. Laradip or Zanidip we are using in my country.
It's
Uh,
radipine.
yes. So that is less edema with this drug, but it is not very potent hypertensive.
What is that medication?
Laradip I use.
What is
What
that?
is
It's radipine. It's another calcium channel blocker.
Calcium blocker. Yeah. Okay.
Yeah, yeah.
So
Yeah, yeah.
same thing.
That
Same
is
thing.
also good. It doesn't
Okay.
do any peripheral edema.
Oh, that's good. I mean, all the medication are in same classes have slight difference. For example, I don't know. Let me ask you, my colleague here in America, losartan as a blood pressure medication doesn't consider to be very potent, although you cannot prove that. But many of my hypertension colleagues think that way, and also
Yes.
losartan is not a good blood pressure medication, but it's had all the other effects. If you want to
Yes.
put somebody on ARBs inhibitor, but you don't want to, for other renal or cardiac protection, don't want to decrease blood pressure too much, then you want to put losartan. So
Losartan,
there
yes.
is a class difference also. So maybe one cause less edema than other. So that's your experience. That's good.
Yes, very right. Very right. Candesartan is the most potent antihypertensive I found.
Yeah, so we learn from each other's experience. That's good. So let me ask you, Father, I mean, you guys think the same thing about the losartan, or that's just like a myth? Compared to valsartan and losartan is less potent and even the equivalent dose. Same thing, yeah. So do you guys have the same experience or not really? Not everybody agreed to that, and I won't blame them because there's no study showing
I
that.
find losartan to be the weakest. There's no question
Okay.
in my mind.
Okay.
The one thing I try to add is that losartan has an anti-uricemic effect.
Yes.
So in patients who have metabolic syndromes, I tend to use that losartan as a dual effect on that. But otherwise, yeah, losartan is shorter half-life. It's not 24 hours. I think it's 16 or 18 hours half-life or something. So I tend to change my losartan patients who have resistant hypertension to either valsartan or candesartan or something like this.
I mean, similarly in ACE inhibitor, ramipril has the same thing. It's not very potent as blood pressure antihypertensive effect compared to lisinopril and other medication, but has all the other benefits of ACE inhibitor for renal or cardiac protection.
So are you proposing, Wes, that the renoprotective and cardioprotective effect is independent of the antihypertensive effect?
Yes. I mean,
And how does
I can prove that, but it has been used in all this. In fact, that's basically more like talking to informal discussion with cardiologists and nephrologists that if you don't want to decrease the blood pressure, but you want to have other effects, these medication.
The question then what I would ask is, are we actually seeing those other effects? Because there's no way for us to measure those other effects.
I doubt if you can do that. But anyway, I'm just sharing my experience.
I think outcome data will tell us the other outcomes, the cardiovascular and the other. And I remember there was studies, so head-to-head comparison. Losartan actually was among the class, the only one which had some low risk of stroke. Again, like those are the outcome types of study and data. And then you saw some signal or noise.
Reduction in proteinuria also. Yeah.
No, ramipril has been used in some studies also, and it showed that it does have.
The big HOPE trial was all ramipril. So
yeah. So ramipril showed that.
I think reduction in the proteinuria may also elicit that.
Yeah.
Good. Okay. Looks like we are coming towards the end of our session today.
I have one more question about the calcium channel blockers. I mean, for the panelists, what would be is there any choice difference between these dihydropyridine and non-dihydropyridine, and what would be your, go-to medication Any scenarios that you would prefer one over the other?
I mean, I don't consider that non-dihydropiridine medication as a blood pressure medication. These are basically heart medication. Patient has AFib, something like that. These are not blood pressure medication, in my opinion. So dual calcium blocker, you give only if patient is on ACE inhibitor, diltiazem because of AFib or some other reason, and you patient already on ARBs or ACE inhibitor, blood pressure is still high, and you said, okay, what I can do? So then you add nifedipine or nifedipine to that. But I don't consider even beta blocker a blood pressure medication, but verapamil or diltiazem are not really blood pressure medication. Would not be my first or second or third choice.
Thank you.
There's no blood pressure trial which use these medication as even not even first, second, third. I mean, they have used many medications. You will not see any blood pressure trial where you use diltiazem or verapamil. They use doxazosine, that they use all the hydralazine even sometimes as added medication. Clonidine even sometimes added medication, but not.
The problem we have here in Pakistan is that hydralazine is short, clonidine is not available. And if cardio or doxazosine don't work, then we don't have many other choices here.
Obviously, you have to do whatever you're available, but clonidine and hydralazine, you don't miss much. I mean, these are least desirable medication for blood pressure anyway. But whatever you're available, you have to use that. So I understand that.
Anybody has a better experience with Aliskiren in terms of ACE ARBs? I probably have very little experience about Aliskiren. Is there any scenario we would use it for any patient apart from ACE and ARBs?
So that's a direct renin inhibitor, right?
So when it came 10, 15 years ago, actually, we got excited that, okay, new class medication. I use a lot, actually, and the medical rep, he or she used to like me a lot because I was using, and they were preparing me to give a talk in coming days about that. But the experience was not very good and didn't work much in any patient, and I think it pretty much faded away over the years. I don't think that many people using that. How about you guys, Irfan and Umar?
So not much experience. I haven't.
I use a lot. I used a lot in the beginning for a few years, but with not much success.
It was a little bit of a disappointment.
Yes.
Yeah, it was not a good drug.
We were pretty excited about that. Okay, but.
I think that's wonderful discussion. So, any final concluding remarks from Abbas, you first, and then Dr. Agha, and then we will conclude the session.
Well, first of all, I would say again, that was a really wonderful case you presented. Okay, and good teaching point. And I think I will have that app. I'll get that. I will use it. That's another take-home message that use that. That's very good. Otherwise, I mean, I would love, and all of us love to discuss hypertension. Keep putting blood pressure, any question on WhatsApp. So we keep talking about that. This is always refresh our knowledge, and different condition, like in Pakistan, you guys have different experience. We learn from that, definitely. So keep bringing, even some is not very exciting or fancy case. You don't have to be, just a general case. I mean, so that's I would ask for.
Thank you very much. Dr. Agha, please, your comments, and then we conclude the session.
No, I think it was a very good discussion. Thank you for Abbas for his expertise. Thank you to you, Umar, for a lovely case. Primary aldosteronism is very, very important. I think we underdiagnose it. does anyone know where captopril was actually discovered from? Anybody? How many? We got 15, 16 people still on the call. So it's actually in the venom of the Brazilian pit viper, right? So that's where captopril is. It's an ACE inhibitor in the venom of a snake. Why would that be? Why would nature have that snake develop an ACE inhibitor in its venom? So Jarakaka is that snake.
Vasodilation, bradykinin, so we can go more, penetrate more and more to the.
It's actually, it's very, very interesting. If you really look at it, why we have so much hypertension in the developed world now. And that is, if you look at these animals, the target of that viper is, moles and rats and shrews and stuff like that. In these animals is even higher mammals, even human beings who live in these little tribes in Brazil and Africa who still follow the old diet. They actually consume less than 100 milligrams, sometimes less than 50 milligrams. I'm talking about humans, not talking about animals, less than 50 milligrams of salt a day. And they consume somewhere around 3,000 milligrams of potassium every day. So the diet is almost the converse of what your diet is and mine. With that chicken biryani that we eat, there's a lot of salt. So 50 milligrams of salt is in a few potato chips, it's not even the full bag. And so the way the primitive man and these mammals maintain their blood pressure is through a very highly revved up renin-angiotensin system. So it's maxed out. So in these Brazilian people or African people, if you measure their renins and aldosterones, they'll be off the chart. But this is renin dependent hyperaldosteronism. And that's why when that Brazilian pit viper bites them, the ACE inhibitor kills that renin-angiotensin drive and they go into shock and they die. So that's the difference in diet. Now, our diet is very, very different. And so with our amount of sodium loading and volume expansion, most people, the renin and aldosterone levels should be really, really suppressed. So somebody who's already experiencing hypertension and their renin level is suppressed, but their aldosterone level is high at 8 or 9 or 10 or 12, start thinking about the mechanism of that hypertension. We are introducing aldactone very late into the game, and we are thinking about primary aldosteronism very late. Like in Umar's patient, the patient had primary aldosteronism 5 years ago. He was diagnosed 5 years late because we follow these cutoffs. So that would be my final thought of the day, that think about the pathophysiology, think of what is under the surface, what's driving the hypertension, identify people who may be at higher risk of primary aldosteronism, even if their numbers don't warrant further testing, try aldosterone sooner rather than as the fifth change drug.
It's definitely underdiagnosed, absolutely.
Thank you. When nothing goes right, take a left turn. So
very rightly said, Dr. Agha. Vice President.
Absolutely.
Thank you. मेरा ख्याल है कि अब तो 12 क्या टाइम हो गया, 12 तो बजने वाले होंगे पाकिस्तान में भी।
हाँ जी, 11:15 हुए हैं, अभी पूरे नहीं बजे।
हमेशा जो है ना जरा टाइम का एहसास होता है, तो इसलिए मेरा दिल करता है कि सेशन की लेंथ जो है वो ठीक हो। आई नो कि हमें तो अच्छा लगता है बात करना, लेकिन आई थिंक हमने फ्यूचर में भी सेशन करने। सबका बहुत बहुत शुक्रिया ज्वाइन करने का, आने का, कंट्रीब्यूट करने का, सुनने का और पार्टिसिपेट करने का। अल्लाह ताला आपको हामी नासिर हो। इंशाल्लाह अगले महीने मिलेंगे। अस्सलाम वालेकुम।
थैंक यू, अल्लाह हाफिज़।